It's my great pleasure now to introduce Hayley Russell, who is from Ovarian Cancer Australia. And if you read in the bio, she has really impressive background in psycho-oncology and also interpreting health and well-being. And I think the data we're about to hear now will be, really pivotal for us understanding other things that we should be doing for our patients. Thank you, Hayley.
Thanks so much, Claire. Yes, you can see my slides. You can see here my background is in counselling when I'm not at Ovarian Cancer Australia, which I have been for 7 years now or more. I work in community palliative care as well. So if Alison felt like the odd one out before, even more so I do, but I'm very, very excited to be here today. So why? Let me get this clicker right first. Oh, got it. So why is it important to have this discussion today and present some of this data? I'll use quite a few words from women with ovarian cancer today, and so this particular woman who responded to our consumer survey back in 2017 spoke about the psychological impact was and continues to be the hardest thing for me. Physically, I coped reasonably well with it all. The reality of survival statistics, though, is challenging. The fear of recurrence is debilitating at times, as is the fear of potentially ultimately succumbing to the disease. So what I want to speak about today is another arm of scientific research which can really improve quality of life and which is really important to Ovarian Cancer Australia. I want to talk a little bit about the origins of psychosocial research at OCA because it's been quite a few years now that it's been important to us. So we did do a really significant consumer survey back in 2017, and of course we wanted to look at what was working for women in our support, but we also came up with a lot of unmet needs, and a lot of them were psychosocially based. We knew, of course, speaking to women every day, we knew that psychological impacts were huge. We had this anecdotal knowledge, but there's a really limited evidence base in Australia. So we thought we'd have a role here in encouraging more research. We began to create these relationships with, as you can see here, the University of Melbourne, Sydney, QUT and South Australia, as well as others. And the first step for us was really looking at a bit of a Delphi study to look at what are the priorities that we should have in psychosocial research. So we spoke to health professionals, women with ovarian cancer, and also academics about what they felt were the top priorities. And you can see them listed here. So we're looking at fear of cancer occurrence, effective psychosocial interventions, end-of-life issues, and we go a little bit into family and caregiver concerns as well. So this is the originating work in 2019. This was done with Louise Sharp at the University of Sydney and her student Estelle Guarin, which has shaped what we've done since then. So I'll take you through some of the more significant collaborations and findings that we've had over the last few years in our collaborations. So when we talk about something like our consumer survey, in fact, a lot of the things that we do, whenever we give people the opportunity, they write pages and pages about their experience with ovarian cancer. We can't stop them, they write novels. It's amazing. And there's so much really rich data in there. So we, again, had decided on this project with Louise Sharp and her student, Jit, at looking at all of that qualitative data. There was 219 people with ovarian cancer who responded, and creating a bit of a model around what we know around unmet needs, buffers and their interactions. So I also wish I had a bit of a pointer here now, but I don't. So we know that uncertainty is a big factor for patients. That uncertainty gave rise to fears for the future. Those fears were exacerbated when they didn't have the information or they had healthcare needs which remained unmet. So those fears were enhanced in that case. And they were also enhanced if they had treatment-related difficulties, which we know, a vast majority of patients do. For some individuals, those fears then led to disruption and isolation in their lives, but you can see there that there were buffers there that did help that impact. So if they did have that social support and certain response and coping styles, then that protected them somewhat. So going now to a different issue, which again had come up in our consumer survey and in our Delphi study as an area of importance. We did a large study on sexuality, body image and relationship with Leslie Stafford at the University of Melbourne and Royal Women's Hospital and some of her students there. One of the papers that we put out around that was people's experience during medical treatment of whether sexuality was being addressed or not. So you can see that only 22% of women were asked at all about sexuality or had a health professional discuss this with them, and a very small percentage, only about 8%, and our cohort was around 100 or so, were offered any referrals. And really importantly, some of these women were talking 3, 4, 5 years later. There was a significant proportion who still wanted to have these discussions further down the track. So on that same study, we also looked at, again, the correlative, same situation. We had lots and lots of correlative data from this study. We looked at women's experiences. We had the same team, but what we did was we actually added a socio-cultural lens across this. We have a fantastic relationship with Sally Boding at the University of South Australia, who's doing a PhD around self-identity and gynecological cancer. So we worked with her and we came to these themes that you can see here. So failure and loss of femininity and womanhood. So we know that treatment results in hormonal changes, loss of fertility and reproductive organs. Participants spoke about this as feeling like a failure and that they were less than in terms of their own femininity and womanhood. And then they identified it with isolation. I'm different to the people around me. It's a point of difference between me and other women. We looked at internalising public perceptions of the self. So we knew that body image was shifting due to physical. They felt physical factors such as scarring or weight gain, those kind of things. But they often associated that sense with how does the world see me now? Do they know that this is because of cancer, or do they think this is because of lifestyle choices? They literally spoke about walking down the street and the eyes of the world being on them. There are always exceptions to this. We also had women who spoke about their scars being their battle scars and giving them strength. So there was always exceptions to this as well, which just highlights the complexity of these issues. And then finally, we also looked into altered relationships, so a loss of the sexual self and relationship burden. So we know that changes reported include change in physical response, painful sex or fear of painful sex, and loss of libido. So women were talking about this leading to a decrease in sexual activity and then a changed or perceived change to their partnered relationship. So they acknowledged that this was partially physical changes, but then they also the psychological changes that came with it as well. And there was a lot of grief and distress around that change and that loss for them. We then also had a variety of experiences in terms of the emotional connection with a partner if they were in partnered relationships. Some felt the emotional connection was deepened, but there was still a lot of guilt referred to in terms of what the relationship could and couldn't be now after treatment. Okay, so before I move on, I'll just give you the chance to read this quote, which was from the sexuality study, just again highlights that isolation and that sense of feeling withdrawn from the world as a woman with ovarian cancer in her 30s in this case. So the other area that we have done quite a bit of work in is fear of cancer recurrence and fear of cancer progression. So we've done some quite detailed explorations, and if you read the titles of our papers up there, you can see we're really looking to the psychological underpinnings behind these fears and the impact they have on everyday life. We also, something to mention, which I should have mentioned on the last slide, is the translational aspect of all this work. So everything that we do in this area translates to written resources, to different new support services at Ovarian Cancer Australia as well. So For instance, we had an online booklet that we had, and then we did the research into, is this actually sufficient, which we found it was acceptable. Women really enjoyed the resource, but it wasn't sufficient to reduce that fear of cancer occurrence as if it was at a higher clinical level. So all of this gives us ideas in terms of what we need in terms of further psychological interventions into the future. We've also done some work with Monash University into carer needs and psychological wellbeing. So in a way, unsurprisingly, we know that clinical levels of fear of cancer occurrence are also experienced by carers. And you can see there that there was significant or moderate or severe levels of anxiety and depression in 1 in 5 carers, and moderate or severe levels in both anxiety and depression. And a lot of their common challenges mirrored people with ovarian cancer. So this work I'm going to do is talk about is the great work of Chanel Pereira. So if you have questions, please do approach. I really encourage you to take a look at the registry's annual report, where there are copies out there at the desk, and she'll be there as well. So we have the registry, of course, that you can read about, but we wanted to incorporate patient-reported outcome measures and patient-reported experience measures in the ovarian cancer module. So Chanel and her team did some amazing background work to establish the most appropriate measures, which you can see up there on screen, and began collecting some data on what women thought about these measures. We did focus groups to gather some qualitative data, and these are some of the themes. And again, we're getting a little bit repetitive here because the same themes come up over and over again, that what's most important is physical side effects and the way they impact independence, psychological impacts and personal identity, emotional well-being and intimacy, and stress and anxiety due to fear of cancer occurrence. So that work did find that the tools were acceptable to people, all the items were important, they were happy to do that every 6 months and to do that online, though they wanted a paper version as well. And I'm just really glad that we're involved in this work, because what it will mean when it is incorporated is that these questions are being asked, so it makes it more acceptable for women to actually raise those psychosocial issues and potentially result in referrals and other help in this area. So I'll just talk about what's next on our radar. As I briefly spoke about, everything we do relates in translational work. So we're so fortunate to have these collaborations to be able to help hugely, obviously, with recruitment to these projects, and then to come through to support services. So when you walk outside to the table, you will see our written resources on for partners on sexuality, body image and relationships, and those have also created things like support groups for partners, and sexuality-specific clinics for sexuality counselling. We want to keep on refining our knowledge of fear of cancer occurrence and progression. We know it's huge for people. We're involved in a randomised control trial at the moment of I Conquer Fear, which is an online intervention for fear of cancer occurrence. And we're looking at other ways about how fear of cancer occurrence manifests in ovarian cancer, and extending into some other areas such as sleep, menopause and its symptoms. And that's me.
Thank you so much, Hayley. I think so much of what you've raised, we would see in our everyday lives, in our clinics, and having more resources to be able to manage that would be absolutely fantastic. And also that prod to ask the questions, like asking about exercise. I think it's the whole life and effects on the whole life that really also then determine everything about how a patient can be treated and her treatment decisions, don't they?
Yeah.
One question? 7 minutes.
Thanks, Hayley. That was really excellent. I have 2 questions. One is, when you did your survey of patients through your Ovarian Cancer Australia, did you collect any demographics about the respondents? And the second question is, how do you address the needs of those women who maybe have less health literacy and lower sociodemographics, who are unlikely to be the people that write a novel when you ask them a question, or are unlikely to even respond to your questionnaire.
Yes, thank you. Yeah, so
like people at Westmead Hospital.
Yeah, absolutely, absolutely. So there's a few things there. So the consumer survey, which we did in 2017, and we redid in 2021 as well. So we had some demographic aspects, and we knew that it mirrored in terms of age, a rural regional status, that we were sort of mirroring what we know is the general population. The comment around access, one thing that I think is really fantastic is with the PREMS and PROMS work that we just spoke about, the measures that we chose are available in different languages. So women may actually get that if they're part of the Ovarian Cancer Registry, and that may prompt in their own language, okay, maybe I'm starting to think about that emotional issue. But it's a constant with us in building what we have available for core populations, other populations, and essentially trying to get the funding to translate everything into every language would be fantastic. Yeah.
And I'll put a shout out for NGOR as well, because that is the way you're going to get everybody, because it's an opt-out system. So everybody will potentially get the questionnaire, and it's only those, which is about 5%, I think, John, is that about right? Oh, Chanel, there's only about 5% who opt out. So that means of all those people that we register, 95% of them will get the opportunity to tell their story, which I think is really important.
Yeah.
What a great note to finish on. The more data, the better. Thank you very much, Hayley.